Design is everywhere.
So are we.
Design Museum Boston is supported by members like you.
Unlock a world of design by becoming a member of Design Museum Boston.
Thank you, everyone here. I am the Experience Strategy Director here at Mad Pow. I have a rather interesting background where I was an architect for a while, many years ago, designing healthcare spaces, and after that decided to really focus on the service of what's happening within spaces and the activities that happen within them. I actually was at Continuum for 5 years as a service designer. From there I went to Philips to be a patient experience consultant, actually looking at how patients experience spaces, what their needs are, what solutions should be towards them. And then from there, moving on to Mad Pow, where I am now, really advocating for patients as much as humanly possible, and doing that through many different methods and processes therein. When I was asked actually to moderate this panel, let's see if my clicker works. Does it? It doesn't. You got it? You got it. One more. That's all I need. Yes. So I was thinking to myself, okay, so they asked me to moderate this panel and to talk about healthcare environment. So one of my old jobs was to audit hospitals and to look at their systems and look at how their processes work and look at specifically their environments and how we can make those improvements, which actually is a strange experience because I can get into facilities before they open. And this is a picture of University of Kentucky Medical Center the day before their ER department opened. And I thought, oh, this is actually a great photo for today. I can show this as that example of a healthcare environment, and we can say, hey, everybody, this is what we're here to talk about. And then I pulled up this shot. I'm staring at it for the past 3 days, and it's really freaking me out. And for the life of me, I could not figure out what the problem is and why this is such a freaky photo to me. And does anyone here see what is blatantly missing from this photo, which is a serious problem? Yeah, people, right? I had, what I realized was that all these environments, and if we look at them just in terms of the physicality of the space itself, is void of the most important thing there, which is actually the humanistic side of things, the person. So if you go to the next slide, yeah, you're on this. This is awesome. This is the reality of an ER. This is not after a natural disaster. This is Thursday, and this is basically what we need to design for. It's not clean spaces or beautiful lines or perfect materials. It is how humans are interacting within a space and what their actual needs are. The reality is that an ER will be swamped like this, and how do we actually understand those different capacity needs and what the experience is for that person going through that experience, or a family member waiting to find out good news or bad news and those different aspects of it. And this actually, to me, got this thought around that the needs and requirements, and you can start to cycle through the rest of these, the needs and requirements of a healthcare space are immense. And when you look at a lot of different industries, whether it's automotive or selling a car, or even comparative models in terms of user expectations, like going to a restaurant, there isn't a huge amount of pressure on those systems to change or to evolve. But when we look at a healthcare environment, it is a massive amount of outside influences, these dynamic change influences that are forcing change, and it's forcing change constantly. And even right now as we speak, that number of changes that are required are immense in terms of advocating for and understanding that the processes that are in place for patients are appropriate, and that staff are supported with those different processes to make sure that errors aren't being made, and that data is accurate, and that the procedures are accurate towards that extent. Advocating for and understanding that there are actions and physical things that are happening in these spaces, counting things like footfalls, understanding how far a nurse has to walk down a hall 16 times a day or 300 times a day. All these different things are there that are important, and not just from the perspective of a staff member, but also looking at things like how technology is infusing into these situations more and more. We are currently being bombarded in every shape, way, and form with new solutions and new technologies, whether it's an Epic system being installed, whether it's the fact that Apple just announced, or actually was leaked yesterday, that Apple's core and primary industry market for the iWatch is not consumers, it is the healthcare industry. And that healthcare environments is their #1 target market right now. And they hired a new C-level individual whose only job will be to market towards healthcare facilities and healthcare marketing environments for the iWatch. That is going to become the first true industry that they think that this thing will explode in. And to know that the pioneering aspects of technology are being focused in these environments that stresses these environments so much. It's asking for this level of flexibility. It's asking for this change. And this is not easy solutions. For those of us who are actually designing to these are just a few of hundreds of different outside influences that are asking so much out of these spaces. And that's what I wanted to talk about. I want to talk about these influences, these outside motivators that are forcing change so rapidly within the healthcare environment, and at the same time advocating for continuously people and understanding that the humanistic value is that important. So that's what I wanted to start with. I wanted to actually start with our panel. We're going to start wide and high in terms of how do we actually advocate for individuals, for human beings. And from there, we'll actually look at some of those different nuances as to how we do that. So with that in mind, let me introduce the panel of speakers. I am lame. I don't have a fancy iPad to read this. I have a ripped piece of paper to read you this on, because that's my style. So to my immediate left is Jessica Finch. She's the art program manager at Boston Children's Hospital. I can tell you from experience, because I've been to Boston Children's many times, and my son has been there with me, that the distractions, the interactions, the nuances to the space in terms of how art and sculpture and those elements influence the overall experience is massive. The difference between a successful visit with your son to a healthcare facility could be whether or not he throws that massive tantrum halfway through. And you're praying the whole time that doesn't happen. And in these different ways, any way to create that, either that distraction or that thing that just catches his attention is hugely important, and I am immensely thankful for the things that you do there, because it's made my experiences very, very easy in that sense. Next to Jessica is Lee Moreau. I've never heard of him, except I worked with him for 5 years when I was at Continuum. Lee is a principal at Continuum. He is an architect turned strategist, and I'm an architect turned strategist. How cool is that? Like, that doesn't happen, but the two people in the world that actually follow that weird career path are in the same room with you, which is pretty cool. So see, Lee is looking at things from an experience point of view and advocating for users in that sense. And if you notice, I actually haven't read any of what's on here for either one of you guys. I apologize. So looking at and understanding architecture and the elements of space, but at the same time translating those into multiple different types of experiences and strategies is something that I've worked with Lee many times on, and he's basically a master of it. Next to Lee is David Burtson, Senior Project Manager at Partners Healthcare. I've had a 5-minute conversation with David and realized that the guy does not think small in terms of the levels of abilities and things that he's working on. If it's a 940,000 square foot facility to combine all utilities and internal staff for partners or different elements of that nature, these are large and complex problems that have massive reward if done correctly. And that is something that David is focusing on, these systematic level, large scale projects that have huge impacts towards an organization like Partners. So that's our panel. Not bad, right? I think I did a pretty good job on that one. Check that one off is done, thank God. So let's get into an actual discussion here. I mentioned this whole idea of the humanistic perspective, or this human value. For the things that you guys work on, how do you advocate for the humanistic side of what you're doing? How do you advocate for people?
So I guess I'll start. I'm an architect. I don't call myself a strategist. I'm actually a client as well as an architect. So strategy comes with the territory, I think. Work in the real estate group in Partners. So we find, and we're part of a small cabal of architects, designers in-house. We don't actually design, but we have a lot of influence over what we build and how it comes out. And it is, end of the day, all about the patient experience, the quality of the patient experience, delivery of excellent healthcare services in an appropriate and as stress-free an environment as possible. It really, I think, the key for me and projects that I've worked on that I think have been somewhat successful is bringing in a wide diversity of perspective, points of views, skill sets. Yes, we work with architects and engineers, and we work with the very best, but it doesn't stop there. We include environmental graphics, digital media, artists, and it's that combination, that sort of unpredictable mix that I think creates the most appropriate and rewarding and successful places for patient experience, for positive healthcare outcomes, for family and visitor engagement, for community connectivity. Those are all very important to what we do. And so I would just say it's about bringing in a large team of folks and trying to keep everybody moving in the same direction. That's really the key to what we do when we do it well.
I would say, at Continuum, we just look very closely at human behavior. So whether that's in a project for a restaurant or in financial services or in healthcare, you just look very deeply at what people are doing. And more importantly, try to understand what people actually need and what they want. And we use ethnographic processes to listen. And I think listening is the most important thing. And in an industry as functional as healthcare, where so much of the infrastructure is extremely complex, and it's just trying to accomplish certain tasks all the way through. You're being pushed through a series of boxes are being checked as you move through the experience. That's really what it feels like. But to really understand what the consumer is looking for, what the patient is looking for, and to try to build a responsive environment that caters to their needs is really fundamentally what we do. And I think being able to translate learnings from one industry to another is really valuable. So obviously doing work in hospitality translates very nicely into something like healthcare. And we're always trying to look for ways to leverage our learning in one sector into another. And I think, I would say half of our work last year was in the healthcare market, whether it's payer, provider, or developing new patient experiences through devices or spaces. So it's something that we're looking at all the time, and we have a long history of looking at the human and patient experience in healthcare.
I would just say that this whole shift to focusing on the patient and family experience has been awesome for art. It has been very helpful for art because suddenly this is something that can personalize the space, can help people have very specific, memorable visual for where they're supposed to go when they're trying to get to their appointment with wayfinding. And one thing that I've seen change quite a bit as I've been at Children's is the emphasis on giving patients control over their environment, and ways that we've tried to do that with the art program, if it's a piece that is touch sensitive or movement sensitive. There's some lights we did in the patient rooms where they can they can actually have the art changed out by a staff person, but they can just also select a different color scheme or a nightlight function or that sort of thing. So that the art has even gotten more technology based, but yeah, just a huge shift, just even in the time that I've been around this field where people are looking at the patient experience and all the different ways that they can influence that. So the art has kind of moved into a little bit different realm, I think, than it would have before, where it's sort of an afterthought. So, for example, now I get involved right at the beginning in schematic design, and I'm thinking about how people are moving through the space versus the space has been designed and you've got some blank walls and you're going to hang some stuff up. So, have you seen a big shift in that, David?
I have, and I mean, there are a few slides in the deck somewhere here that'll come by at some point. I sort of brought a few shots of the Spaulding Rehabilitation Hospital as a kind of case study that we opened in the Charlestown Navy Yard a couple of years ago. The art program is a huge component of what that place is about. We probably got away with more because it's a post-acute care facility,
Yep.
and that folks are there for longer stays, typically I think 25-day average stay. So it's not, we have a whole continuum, if I may, of healthcare venues within our partners network, from the acutes, typically very short stays, very intensive, invasive experience, to the post-acute where you're there for rehabilitation, gone through serious trauma and trying to regain functionality, your life, to the kind of community-based longer-term care, skilled nursing facilities, to outpatient facilities, to home care. So there's this whole spectrum, and design is a key component at each of these stages. But at Spalding, because it is post-acute, and because we had a very passionate CEO who really cared about the quality of the environment and about the art, we were able to develop a pretty robust art program in the public spaces, in the patient rooms, in the outpatient clinic, all the way through the facility. And it's just contributed enormously, I think, to patient satisfaction, again, patient outcomes, visitor satisfaction. We commissioned a 2-story hand-blown glass tile wall in our main lobby. The artist named Paul Hausberg out of Rhode Island did a terrific job, used a 3-generation family glass studio in Germany, laminated these beautiful colored tiles to mirrored backing. So you've got this wonderful kind of shimmering, kind of blue-orange range wall in front of you with a lot of wood, a lot of warm materials when you come in the front door. And we've had patients tell us, just how reassuring that's been when they come in, again, this very fraught state of mind. So yeah, art has a huge role to play, all the way down to the, the sort of natural images we have in the patient rooms.
You mentioned this idea of length of stay, and that when it's a 20-day or 24-day, it makes sense for the investment, because there's that long-term impact and there's that long-term kind of interaction that takes place. The industry as a whole, though, is pushing more and more, because of the way the business models are changing, to minimizing stays as much as possible. Right. And that's not something that's probably going to change in the near future. Knowing that, have you at all felt, all three of you, have you felt that the prioritization has been minimized in the environment because of that, knowing that the stay and the actual ability to impact has changed, because the amount of time that you have the opportunity to engage with the patient is so quick and so functional now, as opposed to more of an experiential aspect of it?
Yeah, I mean, it's really that pressure that allowed us to realize the Spalding and move them from Nashua Street out to the Navy Yard, because the acute hospitals, Mass General, Brigham and Women in our system, children certainly as well, are under such enormous pressure to reduce length of stay, to turn those beds over. To generate that revenue, frankly. We were able to subsidize from the acutes the construction of this post-acute facility for these longer-term stays, because they would realize, frankly, more revenue on the acute side, which is what drives the whole system. Post-acute care, rehabilitation care is a money loser. So Spalding could never have done this under their own steam. They depended on that pressure to kind of decant those acute beds in order to make this happen.
I would say that I think if you talk to most people about the design of hospitals and healthcare facilities, and you said, if you ask them, do you care about what the outside of the building looks like? Nobody cares. I mean, there's probably some architects here who design hospitals, and sorry, but honestly, nobody cares about what the outside of the hospital looks like. You care about the things that you touch, especially if you're sick or you have a toddler, with you going through the experience, or you're seeing a loved one. You don't care about the outside. But you do deeply care about those things that you do engage and you do touch, however briefly. And so, I don't think there's a diminished emphasis on that. I think what I think is happening, though, is that we built healthcare facilities as structures that basically allowed processes to happen and systems to exist. And then we started focusing on the patient experience a little bit more, and that changed our attention as designers. And I think that's all great. And I think what's also starting to happen is now we're focusing our attention on what is it like for the staff inside. And I think that's a really great, we're kind of going full circle, because now, if you talk to nurses, they don't take a break. They don't want to be seen as taking a break, because they are tough. And they don't go to the break room. They'll take a break while they're eating, and they're still charting or whatever. And so I think designing for not just the patient, but also for the providers as well, we're just kind of turning a corner in a really great way. So I think all these surfaces are interesting, and I'm wondering when art becomes not just for the patient, but also for the provider. And I'm sure you're already starting to tackle those issues. That's like.
There's a lot of emphasis on the caring for the caregiver and how one thing that we've been doing is lots of mock-ups. I'm sure you guys go through this. So we try to build out, where's the nurse station going to be versus all of that, and build out those things ahead of time. And there was just recently the Med Ed conference or whatever that was in Boston, and one of the senior planners in our department was talking about the simulation rooms and how they're building in all this flexibility, and that's very, very important for the staff too. So I don't know, finding
Third consideration here, or audience here, are the patients, families, and visitors who are a key participant in the whole healing process. And they're also beneficiaries, I think, of this increased attention on not just patient experience, visitor experience, family experience, providing a comfortable place for a family member to sleep overnight. So it's not, you're not sort of propped up on an uncomfortable couch, but you have something that unfolds and, it's really comfortable. I know your firm has designed a wonderful patient room chair, which you can sleep in, kicks back. And this is where design really aids and abets, I think, what we're trying to achieve with the healthcare experience. Again, it's about not just the patient, it's about the family, it's about the staff, it's about the entire community that are part of these facilities.
It's actually an interesting point because if we bring in this notion that the way that care and recovery works now requires that secondary support, whether it's family or somebody else, outside of the confines of control of a traditional healthcare environment, it does mean that a lot of the experiences and processes are taking place outside of the traditional walls of the environment itself. With that in mind, and knowing that is the trend forward, and that home care or self-care or telemedicine or basically the services that reach out to those individuals instead of those individuals coming to centralized systems exist, is there a response to that when it comes to the actual environment design? Do we actually create control outside of those walls somehow, or do we just define that experience further past the traditional boundaries or the ugly outside of a hospital, so to speak?
So I can't speak as directly to the design of the home care environment. I can talk a little bit about the outpatient clinical experience. It's something we pay a lot of attention to. But it comes back to the drivers, this increasing pressure on bringing down the cost of healthcare services delivery, which Partners certainly gets a lot of attention about in various ways. But at the same time, constantly improving the quality of patient care. So driving that out into the communities, into the neighborhoods, into the home is a way to deliver better quality care at a lower cost. This has really been enabled by technology in a huge way. Technology and design, that's what's making that possible. So that we can no longer have to expect everyone to troop into town to the big academic medical centers to get excellent first quality care. More and more of this can be brought out to where people live at a lower cost.
Yeah, I was doing research in San Francisco and in Berkeley actually, and we had gone to this village community, and these are cropping up all over the country if you're not aware of it. So people, particularly in their say older years, as they're aging, are deciding not to move into an assisted living facility, but to live at home in kind of a network. And sometimes there'll be a communal building or something like that. And you pay in and you get services like take me to the grocery store, or pick up this thing that mow my lawn, stuff like that. There are kind of these little services you can tap into. And they have basically accessibility audits where somebody from the village who has a design background or something will come in and assess everything in their house, their range, their bathroom, as to how feasible is this for you as you're growing up. So telemedicine is just putting a lot of pressure onto people's homes, and I don't think we can expect that the large healthcare networks can kind of go into everybody's houses, but I think there has to be some other system through which we are making sure that people are safe. And I think that's there's going to be a pressure moving everybody out of these larger institutions into other settings, and we have to make sure that they're safe for people. And I think we don't have the systems in place to do that yet, but it's clearly going to be an issue.
And retail delivery of healthcare services as kind of intermediary between home care and the big hospital, right? And it's been announced, I think this week, Partners has partnered with MedSpring out of Texas and they're opening 3 for the first time retail urgent care centers around Boston. It's the first time I think that the Partners brand is actually flown on a clinical facility, if you can call it that. And of course, everybody else is doing it, so it's either get in or get left out. Again, this is part of the pressure to deliver better care at a lower cost.
So you mentioned that you're right, and there's more than one variation when it comes to decentralization of services, right? The home care is probably on the extreme side, but there's all these different other variations, whether it's urgent care facilities, retail type settings in terms of care support, lower acuity aspects, individual primary care offices that are outside of the general umbrella. What that's causing though is that there's all these other small nuanced physical locations. They're all now, before there was one environment to control, now there's going to be many environments to control. Now the question is, are you actually controlling that consistency, or are these running rampant in terms of their own personal needs?
I personally, I think this is, and I'd love to hear what you're about to say from a healthcare organization, but I think this is a significant, it's like a big brand play. Unfortunately, freestanding emergency departments and urgent care facilities and all these sort of disaggregation of the big hospital systems just puts your brand in lots of different locations. I'm not sure, I'm not entirely sure that the value is going to be there long term. It's going to be very interesting. What it is doing is it's making sure that hospitals have their names in lots of places and you get a lot of eyeballs. And so the cynical part of me sees it a little bit as a marketing thing. And I think it's a little bit too soon to tell, because there's many ways that you can go. I think, I do think, Kaiser Permanente went to all video visits for PCP visits. I think they turned the switch on that like 6 months ago. So basically any primary care visit that you might have, you can have a video version of it through telemedicine. I think that's awesome. And do they end up leapfrogging some of that disaggregation of physical locations? I'm not sure I'm answering your question, but I want to challenge the value of this, because I think throwing urgent care facilities all over the place may not be the right approach. Don't know.
And I will agree, brand control is a huge issue for Partners, for Mass General, for the Brigham. We did our first sort of foray into the so-called retail outpatient world about 8 years ago or so. I was involved in the development of the Mass General North Shore Center for Outpatient Care up in Danvers, Mass, which was a partnership between the Mass General Physicians Organization and the North Shore Medical Center in Salem and their docs. We did a similar facility down in Foxborough the Brigham was involved in. I can speak more to the Mass General side. Again, the model was retail healthcare service delivery, lower cost. We're not building a hospital. It's not an academic medical center. We brought in a consultant that had successfully developed similar outpatient clinics connected to medical office buildings in the Midwest, down south. We went around and visited. These are terrific. They're working great. When we tried to import that model to New England, there were some stumbling blocks. It's a different regulatory environment here, different labor environment, just a number of challenges that began to challenge our cost model. And the real kicker was Mass General, sort of halfway through, realized their brand is going to be out there. They had some issues around that time with one of their affiliate hospitals that got dinged in a JCO inspection, so they suddenly sort of focused in, with laser-like intensity, and we had to upgrade a lot of our building systems to more like a hospital standard. So upshot is we did not really deliver at the price point that we had set out to do. It's a great facility, it's very successful, but those are the challenges that we have with kind of brand control and management when we move out into the community. And we'll see how this next generation fares, because I don't think we figured it out yet.
You mentioned, sorry.
Oh, I was just going to say there has been a huge push I'm seeing on getting the less critical patients out to the suburbs a little bit. There's so much congestion where we are in the Longwood medical area. There's very little space to move. And
Except for that garden.
and everyone wants to be there and in the main campus there. So what we're seeing too is because we have top ratings in a lot of these specialties, we've got families coming from all over the world, and so we still have tons and tons of critical care patients, but it's very international. So they're trying to figure out how to cater to that international and really provide the kind of services that those people need too. So there's a whole other aspect of providing housing for families that are here being treated long term and all those kind of things happening. But yeah, definitely trying to get less critical people out. But yeah.
You mentioned in one of your examples the Kaiser Permanente's video chat capability, and that's one of an obscene list of types of technologies that are being either forced on or introduced to healthcare environments. And it becomes a requirement that these facilities be plug and play towards things that we haven't even invented yet, or new systems that are always being in place, or upgrades that have to happen, or even just expectations where I can go to a restaurant and check in on my phone and want that same level of experience at a hospital, or have those expectations of that level of service and B, that level of connected technology. Are you seeing any trends when it comes to levels of technology? Anything that that's going to be disruptive in the future, or even issues when it comes to trying to incorporate things that are coming online now with existing infrastructure?
I mean, what I would say is there are technologies we use every day that are just being adopted by healthcare. Mm-hmm. So, I have a 4-year-old son. He had make a long story short, he had a surgeon who we emailed on the weekend. She emailed us back on a Sunday night because there was some urgency to this conversation. That I did not expect. And I feel like that email is just really a simple technology, but the timing of it was incredible. So to kind of like close the loop on conversations very quickly, I mean, this is not advanced technology. This is like text messaging, emails, very simple stuff. But to use them appropriately and in a timely fashion, I think is new. So it's kind of the pace, the percussive nature of communication now in healthcare is great. I think all the tracking, the potentials of tracking and wearables where you can sort of monitor most of the vitals of certain patients is obviously very promising. I'm not sure how quickly it will be used in a productive way. If we look at how long it took email to get adopted productively by healthcare, I wonder if it's going to take that long for these kind of trackable solutions in the iWatch and so forth to actually be used in a productive way by healthcare. But we'll see. I'm hopeful, but it's interesting.
I mean, I think the email on a Sunday night is impressive. It reminds me, I'm old enough to recall when I was a kid, the family doctor lived up the street, and he would stop by the house on Sunday afternoon if you needed him. And that human touch is hard to replace. Technology is going to have a hard time replacing that. I know, we're looking increasingly at sort of video-based remote diagnosis. I'm not sure whether that's going to take off or not. The technology has been around for a while. I don't know whether Children's is looking at that kind of, mobile robotic diagnostic equipment, but it's something that we've kind of been watching for a while.
Now, in the art space, I know that you've implemented some LED technologies and different aspects into that as well. Can you talk a little bit about how that's working out?
Sure. We do have a lot of interactive displays and things happening in the lobby, but we've tried really hard to bring those things up to where the patients are in the patient rooms and the waiting rooms and those kind of places. So, there's a number of ways that someone could engage with the environment. There's things with imagery, things without imagery. There's ways that they can affect their environment. That comes back to maybe some of that control aspect, which you're in a place where you have very little control over what's happening to you. People are poking and prodding you, and you may not have the language skills or comprehension to really know why you're there or what's going on. So when you first walk into the building or even approach the building, we want them to feel reassured and like it's a friendly place and not a scary place. And then I have heard of families also just bribing their children to come back for repeat visits so that they can play with the media wall or watch the ball machine or do those kind of things. So it's definitely something I think that, as you were saying, the parents appreciate having it there as much as the kids in some ways. So.
What about bedside technology? Again, the issue of patient control, really, really critical. And technology, again, enables this. You can give the patient control of not just the TV, but their sort of entire media environment, the shades on the windows, and the lighting in the room. Are you guys looking at that sort of thing? Are you implementing those sorts of technologies?
Yes, they're definitely, they're trying as many ways as they can to have those spaces be customizable.
We've actually gotten pushback from some of the nursing staff that have said, no, we want them to call us, we'll come in, we'll do that for them.
Right.
Which isn't really getting with the program. So those are some of the kind of, inertias that you have to overcome with technology, innovation. Operable windows, we're beginning to see this, not in the acutes yet, but certainly in the post-acute world. We have provided operable sashes in the patient rooms at Spaulding, primarily as a resiliency strategy, seeing what happened in New Orleans after Katrina with Memorial Hospital there, traditional post-war sealed bed tower, lost all power, flooded ground floor, couldn't evacuate, nursing staff having to break the windows out with the furniture so the patients could breathe. So operable windows suddenly make sense again after 50, 60 years in the healthcare environment. But we have to keep them locked as a concession to our mechanical engineers because, they don't want us to be messing with the balancing of those systems. We have active systems in the activity spaces. This is still, again, a kind of evolutionary process. I just spoke with some folks last week that are working in China, and natural ventilation, daylight, natural light, access to light, narrow floor plates are like standard best practice now in Chinese hospitals, which I didn't realize. I think, what about the air quality? But I guess they work around that as best they can. So we have a lot to learn from Europe, from Asia, in terms of our healthcare environments here. We're still kind of stuck in our ways in many ways.
Sorry, go ahead.
Oh, I was just going to say that the sound environment is also very important.
Yes.
I noticed in Spaulding that you guys have this really nice acoustic ceiling and sound absorbing materials and things like that. We did an audio audit of our hospital at one point to just try to see where, especially if you're trying to rest, having the audio environment, what are the smells, what is the air quality, all of that stuff really does affect people's experience as well. So
Getting toxins out of building materials, formaldehydes, that sort of thing. Big push for us, and I would imagine for you too.
I don't think it's a technology, but what you're seeing are services from outside of the healthcare environment being moved in. So pedicures for diabetes patients, really smart thing to do. It's very easy to bring in and internalize it. And what I hope is that I see the potential for major hospitals to actually nestle themselves into shopping malls. So you can imagine, because rather than bring all those services to the hospital, which I think is a bit of a struggle from a business, hospitals run healthcare facilities. They don't necessarily run retail and food and beverage outlets. But if you can kind of position yourself smartly, I think there's a great synergy, obviously, that you can create with patients that are there for long term, or frankly, if you're just going there for a well visit. I can also go to H&M at the same time or something like that. So I think these are things that I think the healthcare industry is starting to think about their adjacencies to other parts of your life as this whole system gets sort of disaggregated.
Well, that's the whole health and wellness initiative. It's no longer enough to just react to disease, to dysfunction, but it's increasingly part of the mission of the healthcare network to be proactive, to promote healthy behaviors, wellness in the general population, so that, again, you're reducing incidents of trauma, of acute care, and managing your costs.
I honestly don't understand why there isn't a hospital that just plunked itself next to the Cambridge-side Galleria. That just seems completely, you're near transit, it just seems obvious. So what's stopping us?
With that element of so that brings certain emotional aspects to the overall experience, right? Having services to that extent, whether it's just feeling human again after a day of being interacting with machines all day, or whatever that is, or even the notions of control, right? These are aspects of focus that are important for those of us who are here who have to advocate for what are the most important elements of that humanistic value to champion. What do you think those are? Is control the most important, or are there other aspects we should be advocating for?
I would have said dignity, and I think that I think people, when they're in need, are comfortable being poked and prodded. But if it's not done in a respectful way, or if the setting in which that activity takes place doesn't make them feel comfortable, or at least confident in the processes that are taking place, I think that's a problem. And I think we really we're getting out ahead of that. I know that most people in healthcare that I talk to are trying to tackle this, but there are serious operational constraints to doing that, which are staffing models that just do not work for trying to treat everyone with dignity. Like, people are running around frantically trying to save lives, and that gets in the way of the kind of service experience that I think ideally we would all want to provide.
Yeah, I mean, one of the things we did in the inpatient floors of Spalding was we sort of blew up the traditional long counter nursing station, first thing you hit when you come off the elevator to the floor. We sort of created this sort of little semicircular area on one side where some of the staff are working, but also decentralized workstations all around the floor. And instead provided this very welcoming little seating area for patients and families. So it becomes a hospitality reception area, as opposed to this like clinical environment you're suddenly stepping into, again, in a state of high stress and anxiety. So it's about getting the staff out, walking, moving around the floor, visible. We have a huddle room for the staff, but it's not behind the walls. It's in a sort of, sculptural, rounded, sort of Star Wars looking shape right out in the middle of the floor. So even if they're not visible, they're there. And so I think this is some of the things that
stormtroopers are there.
Yeah, well, hopefully they're not perceived that way, but perhaps sometimes they are. Yeah.
Yeah, that plays into what I was going to say with combating isolation in whatever ways we can, because, especially with all the infection control and people, if someone's on precautions, the whole family is just supposed to stay in the room. And maybe there's some ways through technology that you can create community where they could be playing a game with the kid in the room next to them somehow. But there's, hospitals being large organizations, I think it's very hard to combat this sort of silos that people are in different disciplines, and just that the parents, I think, get a lot out of just interacting with other parents. Kids want to interact with other kids, and there's ways that we can maybe design the spaces to foster that too. So
Accessibility, universal design, inclusive design, cannot overstress the importance of this. You talk about dignity, and it's amazing how many hospitals and healthcare environments how incredibly inaccessible they can be. I know some of our facilities were audited a few years ago by, I think it was the Center for Independent Living, basically disabilities advocates, and they came up with a pretty long list of non-compliant conditions. So this is something that we're taking a lot more seriously now, certainly in our new facilities, but it's much harder to go back to older facilities that were not designed to anywhere near current accessibility standards. And we talk about going beyond compliance. We certainly work with the Mass Architectural Access Board requirements and ADA, but we try to really get beyond that. And we work with disabilities advocates to kind of think through what the next generation of environments, furnishings, casework need to be. And we're constantly learning. You talked about mock-ups, absolutely critical to build this stuff, and trial it with, folks in wheelchairs, administrators, clinicians, therapists, family members, board members. Bring everybody in. You get amazing feedback that way, and you learn so much. You can really refine the details, the cabinetry, the fixturing, the finishes, in a way that you'll never really be able to understand just drawing it and modeling it in the abstract.
right. Yeah, it's hard. It's hard for them to visualize it, I think, when you're bringing that to the staff and administrators, and they say, "Oh yeah, that looks good," and then they're in the space and they're like, "Why didn't you do this? Why didn't you do that?" So the mock-ups give them a chance to respond to the real thing, which is really helpful.
To go back to the original question about control, I feel like, I want to say I want to feel in control all the time, but honestly, I think there are moments where you don't want to be in control, and so how can we put people in control of the experience at exactly the right time, where it's meaningful to them and it gives them tangible benefit. And sometimes I think humanly acknowledge that in a healthcare environment, we're going to be out of control. And so long as we're kept abreast of what's going on. So if you imagine a child in an oncology clinic where they might be there for an infusion for hours on end, days on end sometimes, or for an extended stay, they know the facility better than their parents. They like the back of their hand, and they run around, they kind of own the place. I mean, that's a context where I think putting that patient, that child in control is exactly the right thing to do at certain moments. Whereas most of the time, you don't really want a child driving their healthcare experience. It's pretty much a bad idea. So it's really how do we calibrate that right, and I think that goes back to dignity. But control, for me, control and dignity are kind of woven together.
Great, thanks guys. I think we are just about out of time.